knee, right? So the posterior-superior part of the sacroiliac joint or the dorsal aspect consists of interosseous ligament uh, of the sacroiliac, which is a fibrous portion. So the red portion that we see on this gross specimen, and the ventral or the lower portion consists of or is covered by the articular cartilage, right? And this is covered with synovium and is L-shaped. So here we see the fibrous portion on the coronal images and the cartilaginous portion below it, right? So, and on coronal, the most superior and the most inferior aspect of the sacroiliac joint, the yellow portion, this comprises of the joint capsule. So, just one second. Yeah. So the term some basic definitions, like we mentioned, the term spondyloarthritis designates to a group of inflammatory arthritis that have a common clinical as well as genetic features. So, what are the common clinical features? They have inflammatory, plethora of findings. So, inflammation is basically at the enthesis. Enthesis is where it's the where the tendons and ligament directly attached to the bone. So enthesitis is the most predominant finding that you find in any spondyloarthritis. Uh, Involvement can be axial or appendicular, and it can be associated with other systemic diseases like suppose anterior uveitis, psoriasis, or inflammatory bowel disease. The genetic spectrum, the most common association is presence of HLA-B27 and absence of rheumatoid factor. Now, depending on predominant clinical manifestations, spondyloarthritis can be classified into, like we mentioned, axial and appendicular, axial and peripheral. Axial would be spine and sacroiliac joint, and peripheral would be the smaller joints, right? Yeah. So this picture just delineates what we just discussed about enthesitis, right? So there is immune-mediated response, and because of the direct attachment to the bone and no interface between the tendon and the bony surface, the erosion predominates at this location. So, axial SPA is characterized by chronic inflammatory back pain, and based on clinical and radiological, features, they can be defined as axial, as ankylosing spondylitis or non-radiographic axial spondyloarthropathy, right? So, just to show you this Venn diagram, so this is axial and this is peripheral spondyloarthritis. Axial spondyloarthritis, wherever there is frank radiographic features or X-ray features of spondyloarthritis, that group comprises of ankylosing spondylitis. And whatever is only positive on MRI and not positive on radiograph is known as non-radiographic axial spondyloarthritis. So that is what is mentioned here, that ankylosing is defined as structural changes that are visible on radiograph on sacroiliac joint. Non-radiographic axial SPA is defined as presence of sacroiliac inflammation that is detected on MRI. And there is presence of HLA-B27 in combination of other typical features. Even clinical features are equally important, if not more. We'll be discussing later, right? So, ankylosing spondylitis is the prototype of immune-mediated inflammatory rheumatic disease. And a few words about peripheral spondyloarthritis. So this is a wide variety of arthritis that includes psoriatic, reactive, inflammatory bowel disease, and other undifferentiated forms of SPA. So now this picture just shows how in olden times the patient of ankylosing spondylitis was the frank deformity used to be inevitable, and how with today's disease modifying drugs, even after frank diagnosis, the patient can still retain their mobility and continue with healthy lifestyle if the disease responds to the treatment, right? Now, one more diagram of, so this diagram basically delineates the importance of enthesitis only. So this is the muscle belly and the tendon going and attaching directly on the bone. So and the this light brown thing, light pink thing is synovium. So like we know, the joint is covered by cartilage, and at the corners of the joint where the cartilage is not there, where the synovium directly attaches to the bone, is called as bare area of the bone. And this is the pathologic, pathology or the site of inflammation in rheumatoid arthritis. However, in SPA, this just adjacent to the synovium or adjacent to the, bare area of the bone where the tendon directly attaches to the bone, this is where enthesitis will be more prominent. So, what are such common conditions? Well, they are along the superior and inferior corners of the vertebral body. They are also at tendoachilles insertion or plantar fascia insertion, or at lateral epicondyle. So, these are the common sites that are involved. Now, this again just recapitulates the differentiating, disease groups. Now, axial SPA again has inflammatory back pain, is seen in younger patients, predominantly male, associated with HLA-B27. Inflammation of spine and sacroiliac joint is commonly seen, and a detection more clinical for SPA than peripheral arthritis, because basically spine is less accessible for exact clinical examination. We have to depend more on lab tests. Here, a zoomed in image, basically CT image, shows the calcification along the inferior and superior marginal aspect of the vertebral body. Now, this is a paper that gives precise definition of when to call things bone marrow edema, and is recommended, and is actually by ASAS criteria. So, while defining active sacroiliitis on MRI, classification on axial spondyloarthritis, that's done by this workshop. So, bone marrow edema is to be studied on a fluid sensitive sequence, or a post contrast sequence. The inflammation must be clearly present, and the typical location, that is along the subchondral aspect and adjacent to the capsule, like we mentioned, is the most precise or characteristic anatomical location for SPA, and so that makes it highly suggestive. Now, like we were saying, the clinical this one whole picture of the patient, right? So it's a plethora of questions that need to be taken into account. The history, the blood picture, that make a patient either more likely or less likely to have a SPA. Now, what are the things in that order, of from maximum to minimum, that make any patient more likely to have a SPA, right? So radiographic feature of sacroiliitis, that's the most significant and carries the most weight. Then comes HLA-B27 serum marker. After that is the role of MRI. So you have to remember that over enthusiastically while reporting, isolated MRs, and especially spine and SI joint, and most commonly we have the least history in these two cases only. So over enthusiastically labeling things as sacroiliitis is also not going to help the patient, because maybe there is a treatable cause for the edema, and that gets missed when you just label it ankylosing spondylitis. So you have to remember, and preferably get a radiograph done if it was not already done. Ask for the history of HLA-B27, obviously. Then if there was a rheumat reference, these things would be automatically mentioned, like frank presence of anterior uveitis, acute, positive family history, respond to NSAID, finger pain or dactylitis, peripheral arthritis, inflammatory bowel disease, other places, enthesitis at other places, inflammatory back pain, elevated CRP, and psoriasis. So everything has a kind of, grading, and everything that becomes positive makes a patient more likely to be diagnosed as a SPA. Similarly, the factors are the same, but the weightage varies a little. So if there is HLA-B27, that was most common in both the things, in positive as well as negative. But if HLA-B27 is negative, there's good negative predictive value that maybe the patient is not of spondyloarthritis. Another most important thing is this black circle. What does it mean? Another likely explanation of the symptom. So the whole history would lead you to it. Now, everything that the factors are the same, and everything that is negative makes a patient sequentially less likely to have SPA. So how do we function in this background and in this knowledge? So we take the history, the age, the gender of the patient. Is there arthritis generally, and are other places involved? Was there psoriatic history, pregnancy, fever, and HLA-B27 status? Now the sequential imaging spectrum that follows in ankylosing spondylitis is, initially there is inflammation, then there is structural changes, then there is something known as a backfill that we'll be discussing, followed by ankylosis, which is the end stage. So we'll be discussing a diagnostic and a classification criteria and touching upon the differentials. So early diagnosis is important to prevent the permanent structural changes. This is another name for ankylosing spondylitis only. It has a spectrum of acronyms that can be asked in your viva, and multiple named signs that you should remember. So on coronal stir image, here we see a non-radiographic axial SPA where there is a frank subchondral, bone marrow edema. Here we see this is radiographic SPA because bilateral ankylosis is seen, and ankylosing spondylitis frank with the Romanus lesions, or the shiny corner sign we know it as, right? Again, same, we see significant sclerosis around the right sacroiliac joint with some joint narrowing. And here the finding is confirmed with surrounding bone marrow edema. Now, just to, put into what we have already discussed in last 10-15 slides, these are two clinical scenarios. So scenario one is low back pain with Achilles enthesiopathy, right? Tendo-Achilles. MRI shows bone marrow edema at sacroiliac joint. Okay. But this patient is a female, is a 50-year-old, and is a marathon runner. So this is low likelihood of ankylosing spondylitis. Why? The disease onset is not that late. It's not 50. It's around 30. Then male is more common than female, and there is a frank cause. The Like, you remember the negative likelihood table in which there was a big black circle of another likelihood explanation of the symptoms. So an old patient and a marathon runner. So all this seems to be a stress response, right? So the low back pain and the because of the pressure, the Achilles tendinopathy must be happening. Now, another example of a patient that also has low backache, and MRI shows no bone marrow edema, but the patient is a male, is of 20 years, has raised CRP, has psoriasis, has HLA-B27 positive, and a family history also. So even though he's young and there is no bone marrow edema on MRI, still this patient is of ankylosing axial spondyloarthropathy and can lead to ankylosing spondylitis if not treated, right? If the disease, when the disease progresses. So that is the importance that we were trying to lay of the whole clinical picture. Now, diagnostic and classification criteria. What does this really mean? So, diagnostic criteria is supposed to be applied to patients in our clinics or by rheumatologist or by any pain physician or ortho person. So, this is diagnostic criteria is applied to individual in clinical practice. What it includes is history taking, examination, and investigations. what we have to do is re-evaluate these findings in response to treatment. So we have to give disease modifying drugs, and then we have to re-evaluate with the history, with the examination, with the blood picture, everything, right? So these are the named diagnostic criteria. New York and Rome criteria are for sacroiliitis, and ESSG or Armour criteria are for axial spondyloarthritis. Now, for the larger study groups in population, or for research, or for labeling if the drug is responding or not, or especially in patients with established diagnosis, ASA's criteria was formed, and it has a high sensitivity and a specificity. Now, in a lot of countries, because of high sensitivity and specificity, to get the drugs, this label is important. So that is why, and because it is intrinsically of good prediction, so a lot of clinicians have started to, in talks, if you discuss with your rheumats, they discuss it as if it's qualifying the ASAS criteria or not. Now, this is the New York criteria that we just discussed for sacroiliitis. And what do we see? Sequential grades of increasing severity of disease. So in grade 1, what are we seeing? We are just seeing some sclerosis along